the two sides of the pigmented mole or spot, and they don't match. So basically put a line through it. Is there symmetry? Great. Asymmetry means loss of symmetry. So one side might look really jagged, the other side looks smooth. Or this follows alongside with border irregularity. The borders are smooth, but they have indentations. So they might look jagged, or as you can see on that example with melanoma, see how it has a waviness to it, a wavy line. Color. Pigmented spots contain several colors. So in other words, not just black. You might have red, brown, black, tans, and blues. The diameter of the spot is larger than 6 millimeters. Now keep in mind, millimeters is really small. Okay? By the time you get to 1 full centimeter, it takes 10 millimeters to equal a centimeter. Then, as you can see there on that diagram there, that's sizable, it's big. And finally, elevation. This has sometimes been added. Elevation means that the actual mole or the actual potential skin cancer has elevated itself above the skin surface, so it rises up above it. Now, some of you might be actually looking at people that you know, or even checking yourself and saying, oh, maybe I have cancer. The best way to do that is you direct someone to a dermatologist and let them do the evaluation. Okay? The next area that we're going to deal with is burns. Now, remember that skin is the physical barrier, the chemical barrier, the biological barrier. Remember that we have both the epidermis and the dermis, and anything below the dermis really gets into what they call fascia or hypodermis. This may be actually near or next to tissue such as muscle or adipose, etc. Now, why am I bringing all of this up? Because I want you to have a clear understanding of this as you deal with understanding of skin burns. And there's a model that is in the lab that shows you on one side all the layers of the skin, and if you flip it around, it shows you the levels of first, second, and third degree. I encourage you that when you next time you get into the lab to look that up. The definition of a burn is tissue damage inflicted by intense heat, but it can also be damaged by electricity, radiation, or certain chemicals. In other words, really strong acids, really strong bases. These are going to denature the proteins. These are going to cause cell death in the affected area. Burns are very serious as they damage or eliminate the protective qualities of skin. Remember, physical, chemical, biological barriers. Burned skin is sterile for about 24 hours. In other words, if you take a look at the third degree burn there, it's not crispy critters there, but you can see some of the edges of it. What they've been doing is doing debridement, okay? If someone receives a third degree burn, you're going to have about 24 hours. But after that, you're going to have a serious issue of potential infection. Bacteria, fungi, other pathogens are going to invade the damaged area due to the presence of a nutrient-rich environment. So you've got dead tissue, and it's weeping interstitial fluid. So you're going to have interstitial fluid there. The pathogens are going to proliferate. It used to be with skin burns, one of the means in which individuals would die would be subsequent infections. Now, here's an important point. After a severe burn, lost fluids must be replaced immediately as the fluid seeps into the burned areas. Loss of fluid is accompanied also by the loss of electrolytes. Okay? Loss of fluid can lead to renal shutdown and circulatory shock. This is inadequate blood circulation due to the reduced blood volume. Also, burn patients need to basically consume or take in thousands of extra food calories daily. They have to replace the lost proteins. They have to provide this for ready tissue repair. And a lot of times, due to the great demand, and that oral replacement may not meet this caloric demand, they have to then do intravenous replacement and possibly gastric tubes. Okay, so a tube going right straight into the stomach. These are used to supply the caloric needs of the patient. We also have what we call the rule of nines. And I want you to take a look at this for a second and try to get it down because it'll help you to understand things in your subsequent nursing courses and when you're out in the field. This is a method of computing the extent of burns by dividing the body into a number of areas, each accounting for 9% of the total area. Now, if you notice there where it says 4.5 and 4.5, if you were to include both front and back of, let's say, that left arm or that right arm, 4.5 times 2 is 9. So left arm, right arm, from fingers all the way up to the arm. If you had just the left arm completely destroyed, that's 9%. If you have the front and the back of the head and neck, the front part's 4.5%, the back part's 4.5%. Okay? You need to also be aware of this too. Hair will burn. And if hair burns, that may complicate the treatment for the burn treatment. It will also be, I hate to say this, but it will be fuel for the fire when the person is getting burnt. If, let's say, it is based on fire, or it may be based on chemical activity, because the chemicals may actually damage the hair. But usually when hair burns, it's going to lead to more extensive damage, okay? The anterior trunk is 8%. The posterior part is, excuse me, not 18%. The anterior trunk is 18%. The posterior is 18%. Taken together, that's 36%. And you can see there you have the 9s there. Front and back of the legs is 9%, 9%. Add it all up, plus the perineum, you've got 100%. Let's just go back here for a second. First degree burn. And you can see that. It's just kind of reddened. It looks like you got a sunburn. Well, sunburn is a first degree burn. Only the epidermis is damaged, the localized redness, pain, swelling. This is pretty much going to heal in 2 to 3 days. Okay? Second degree is more severe. You have injury to the epidermis and the upper layers of the dermis. Symptoms are similar to first degree, but the blisters will appear. Skin regeneration will occur with little scarring within 3 to 4 weeks if infection does not occur. Here's one pointer. 50 years ago, it was common for people to burst the blisters. Nowadays, doctors say don't touch those blisters. The only time you might touch the blister to lance it or to relieve it is if there's bleeding, or if there's a bunch of colors like white and yellow, etc., because it indicates there's infection. Okay? Most of the time, the tissue fluid will be reabsorbed, and the blistered tissue will eventually slough off as there is recovery of function of both the dermis and the epidermis. Okay? Now, when you get partial thickness burns, that's first and second degree. What about third degree? This is the full thickness burn. It involves the entire thickness of the skin. The burned area appears gray-white, cherry red, or blackened. Initially, there's little or no edema. The nerve endings are destroyed, so the patient is going to report no pain at all. Fluid loss and infection can set in before the endogenous skin regeneration can occur. Therefore, this may require skin grafts. The eschar, that is the burned skin, must be removed. That's debriding. Sometimes what they'll do is literally they'll clip it out, cut it out, etc. Sometimes there is a cream that is based on enzymes that will basically dissolve this away. But then to prevent infection, they will use a topical antibiotic. And they may also use some synthetic skin, such as animal cadaver or autografts, to cover the skin. 2 points here. The antibiotic, a lot of times they use silver sulfdiazine, because you wouldn't put this internally, but you can put it as a topical, and it will prevent subsequent infection. Second thing that's interesting is in some parts of the world, they've been trying to use skin from the tilapia fish. And I think that this has been reported in Venezuela as well as in Brazil. Now, that sounds kind of gross, but they've been getting some success in it, in being able to, it's sterilized, obviously, but when they wrap the burn wounds in it, the skin seems to help. It helps give the push for regeneration and recovery. Now, scar tissue may still develop in the burned areas, and the scar tissue is basically fibroblasts developing more or less just scar tissue. This is what we call keloids, okay? Now, conditions for critical burns. If you'll see this in the text, if you have over 25% of the body that has second-degree burns, if you have over 10% of the body that has third-degree burns, and remember the percentages that I gave you a minute ago. Also, if there are third-degree burns of the face, hands, and feet. Facial burns are extremely serious because it is possibility that the upper passage airways are burned. If they are burned, they may, of course, swell, and you're going to have the possibility of suffocation. Okay, that's and then again, also if you're trying to get caloric intake after the patient has been admitted, they may have to then use a gastro tube because basically the upper respiratory is near to the esophagus and it may be damaged in such a way that normal consumption of the calories, drinking and eating, will not be possible initially. Now, the embryology of the skin will be covered later on, usually in AP2. I do encourage you to take time to review the medical terms at the end of the chapter, review the chapter summary, okay? And from this, we're going to get into bones and skeletal tissues. So we move from A to B, and we're going to get right into this. This is going to be now the chapter on the skeletal system. Now, this is going to include both bones, the skeletal system, so we're going to be talking about some cartilage too, so you need to be aware of that, okay? By definition, the skeletal cartilage is cartilage tissue that contains a high amount of water. It's avascular, means it lacks capillary beds, okay? So that means that all the nutrients and all the waste removal is going to be by diffusion. That's a slower process than, let's say, having a capillary bed there. But the tissue is resilient, flexible, but it also lacks nerve fibers, okay? Now, we're going to be dealing with several terms here that we want to get familiarized with. First off is the pericardium. Now, perichondrium. This is, dense, irregular tissue which acts to contain the cartilage. So it's sort of like the barrier. This will provide structural support to prevent expansion of the cartilage while it's under stress or force. The source of blood vessels are going to be present there, and they provide a diffusion of nutrients into the actual cartilage tissue. Chondrocytes, these are the cells that make the cartilage, and they are located in the lacunae. These are the spaces where the chondrocytes reside. If you are a little bit confused, remember to go back to chapter 4, where we talked about the different types of connective tissues and zero in on cartilage. There's 3 different types. Okay, we're going to go through this in a minute. Okay, also you've got to keep in mind that there's going to be an extracellular matrix. It's a jelly-like substance composed of fibers and ground substance. Okay, so if you go through the types of skeletal cartilage, you have hyaline, elastic, and fibrocartilage. Note that it is not just present in the skeletal area, but you will find hyaline cartilage very present in the thyroid cartilage, okay, as part of the larynx, and you will find it as part of the cricoid cartilage and the trachea, keeping the trachea patent, and patent in this case means open, keeping the trachea open to allow respiration. But let's go back to the skeleton now. Okay, in hyaline, only fibers present are fine cartilage fibers, and this is for strength and resilience. And you're going to find them located on the articular cartilage, the ends of the bones with movable joints. So basically in the wrist area, the ankle area. You're going to find them in the knees. You're going to find them in the hip joint. You're going to find them in the elbow joint and in the shoulder joints. Interestingly enough, you're going to find this material called costal cartilage. This also is hyaline cartilage, and this basically connects the ribs to an approach that will connect them to the sternum. Okay, we talked a little bit about this in lab. The elastic cartilage is a little bit different. That's in green. This contains elastin fibers, so it allows for a flexibility to occur. Again, similar to hyaline, more stretchy and flexible, located in the external ear. That's the pinna, okay, as well as the epiglottis. If you take a look where the epiglottis is, it is slightly above and is basically controlling airflow versus food flow at the site where the larynx is. Fibrocartilage is extremely tough. It's highly compressible, has great tensile strength, so it can put a lot of pressure on. So where would you find that? Between the vertebrae, and that's the red that you're going to see there. Okay, you have parallel rows of chondrocytes with thick collagen fibers.